I want to welcome everyone for a LOTUS Valve Symposium, Expanding Treatment Options in Real-World Practice. I'm Ted Feldman, co-chairing with Lars Sondergaard and Thomas Walter, and we have a very packed session. So I'm going to open with session objectives. We will go through our talks and in sequence and then discussion at the end. So I do have an overview of the LOTUS program, and I want to talk a little bit about some background looking forward, because we have a lot in the program on the current LOTUS devices, but I want to point out that the data that we've presented at this meeting and most of our prior experiences with the Generation 1 LOTUS. The next generation device is the LOTUS Edge system. It's distinguished by being lower profile with a 14 French expandable sheath, having a much more flexible catheter shaft rather than the preformed Generation 1, much more flexible shaft, and very importantly, a mechanism of deployment top-down rather than both ends to the middle to minimize interaction with the LVOT, which we believe is an important determinant of pacing. Another challenge with the LOTUS device for new operators has been assessing locking, and the LOTUS Edge will have markers that make it extremely easy to assess locking. So you see a summary of these changes here, first generation compared to LOTUS Edge, and it really is an advance from a first generation to a second generation device. This shows the difference in the guide catheters and more importantly in the locking mechanism, and you can see these markers, and when they're touching the valve is locked, and there's no multiple views needed and no uncertainty about locking. The depth guard process is shown here. The first gen typically extends into the LVOT to some degree during deployment. And with this depth guard deployment feature, it'll be possible to land the lower end of the device and then be confident of less interaction with the LVOT. We've had a very robust clinical research program, and you're going to hear a little bit of these results presented today, particularly the REPRISE 3 pivotal trial results, which we presented yesterday and will review today. There are also a large number of investigator-sponsored trials, and these are ongoing, so that the database supporting the use of this device is going to expand very rapidly. I mentioned the REPRISE 3. I want to give just a little perspective of where the REPRISE patient population fits. It is a high and extreme risk trial, and as you hear the data, I think it's really important to remember that these are high-risk patients that we're going to be talking about in the REPRISE 3 summary today. Many people carry now the 1% and 2% mortality and stroke rate results from intermediate risk trials, and recognizing who the patient population is in each of the various trial subsets is really important. This looks like a confusing slide, but I want to just spend 1 minute. This is kind of the history of randomized TAVR trials. And you can see the high and extreme risk trials here, intermediate risk trials here. I want to focus on high and extreme risk. Partner 1B, landmark, comparing medical therapy and TAVR. 1A, surgical therapy and TAVR. Core valve high risk, surgical therapy and core valve. And here is REPRISE 3. And these are also high risk patients. And you can see that the death and stroke, that is the major adverse event rate at 1 year in the REPRISE 3 trial for core valve, matches very well contemporary mortality and stroke with this platform. And as we have seen with every successive trial, the LOTUS valve represents yet another difference. And we see the whole spectrum of adverse events drop quite dramatically as we move into intermediate risk, and we can anticipate this same trend with low risk. So with that, we have a session agenda here that's going to review a range of topics from our trial data to some really good clinical examples. And with that, maybe Lars, do you want to make the next introduction, and we'll kick off the program. Thank you.
Yes. Thanks, Ted. So we're going to invite Darren Milet to give us an update of the latest clinical data from the LOTUS program.
Thank you. So I have the distinguished pleasure of trying to get through a fairly extensive clinical research program on the LOTUS device in the next 8 minutes before that bar at the top of your screen starts flashing red and telling me to get off the stage. So I'm going to have to move reasonably quickly, so please excuse me. What I'm going to try and focus on initially are the data that's been presented at this meeting, which I think is the most contemporary LOTUS data that's available. And I think there's no place better to start than the REPRISE 3 study that was presented so eloquently by our co-chairperson yesterday. So as most of you will be aware, the REPRISE 3 study is a randomized control study evaluating the LOTUS valve versus core valve, as mentioned earlier, in extreme and high-risk patients. There are a variety of endpoints that we're going to look at: a primary safety endpoint that is non-inferior, a primary efficacy endpoint that is initially non-inferior, and then if the non-inferiority criteria is met, an immediate superiority analysis, and an important focus on a secondary endpoint of relevance because it's related to mortality in the longer term, and that being paravalvular leak. The study itself looked at patients, as I mentioned, at extreme or high operative risk, and all cases were transfemoral. The cases were evaluated by the individual institutional heart teams and by a case review committee, and then randomized in a 2-to-1 fashion to LOTUS valve or core valve. Two important caveats at this point. First of all, the core valve patients were treated, about 50% of them had a traditional classic core valve, and about 50% had an Evolut R, a repositionable device. From the LOTUS valve point of view, it's important to remember, first, this is a first-generation device, and second, that centers were able to recruit after they had done 2 procedures. So a very inexperienced group evaluating the LOTUS valve in particular. All patients, of course, were seen pre- and post-procedure by a neurologist, and of course, the usual clinical and echocardiographic follow-up. Let's look at the trial population that was recruited. Again, typical of a high or extreme risk trial with about a mean age of 83, an STS score of 6.9%, and more than 30% of patients had prior PCI or CABG, atrial fibrillation, or significant lung disease. The primary composite safety endpoint was a non-inferiority endpoint looking at death, stroke, life-threatening or major bleeding, vascular complications, and stage 2 or 3 kidney injury at 30 days. So a very extensive composite endpoint that looks at all of the things that are of relevance to our patients. There's a pre-specified 10.5% non-inferiority margin, and while this may appear generous when this trial was initially designed, you have to remember that vascular complication rates, for example, were in the order of 8 to 10%. So although this is generous, it was of its time. That means that anything on the left-hand side of this line meets the non-inferiority criteria. So these are the results. The actual difference between the 2 valves in looking at this composite endpoint was actually 2.8%. When we take the 97% confidence interval of that, it turns out to be 7.8% at its maximum value, and therefore you can see there is significant room between that non-inferiority margin and the 97.5% confidence interval. Therefore, this means that the non-inferiority margin was easily achieved. Thus, the LOTUS valve is non-inferior to core valve for this very extensive composite primary endpoint. If we have a little look at those clinical outcomes, well, it's important to note that the mortality in these patients was 2.3%. 2.3% in a high-risk patient population with a first-generation device with operators who had not done this before is really exceptional, in my opinion. Pacemakers were an issue. I think it's important to acknowledge that. The pacemaker rate was 35% versus 20%. But again, inexperienced operators, an implant technique that was suboptimal, and I think we're going to hear a little bit more about, and a new device en route that's going to hopefully mitigate that. And I'm going to show you some data looking at that important endpoint. But of course, there are other endpoints that go the other way in terms of malpositioning and so on. That was not required with the LOTUS valve. Demonstrating the improvement, not just with new devices, but indeed with improved operator experience and improved operator technique, we see that those pacemaker rates can fall using a first-generation device with experience and better technique. And this is a sub-study from the main Reprise 3 study presented today by Chris Maggiore from Piedmont. Let's take it back to those important data again. The primary effectiveness endpoint, which was a composite of death, disabling stroke, and moderate PVL at 1 year. Again, the pre-specified endpoint was 9.5%. The actual difference was 12.3% in favor of LOTUS versus CoreValve, and therefore you can see that, again, with ease, that non-inferiority margin was met. Therefore, the device was non-inferior for that primary effectiveness endpoint. I mentioned to you that on achieving that non-inferiority endpoint, that a superiority analysis was immediately conducted, and again, this demonstrates significant benefit for that endpoint relative to the CoreValve. If we look at those that primary effectiveness endpoint and look at the individual components, what was it driven by? Well, it was driven by a numerically lower mortality with the LOTUS valve at 1 year. It was driven by a numerically lower stroke rate at 1 year, and of course the expected moderate or greater PVL rate was lower. So largely driven by the PVL rate, but all of the composites, all of the individual components of that composite endpoint go in the same direction. The hemodynamics were superior for CoreValve. Somewhat disappointing when you look at effective orifice areas of 1.4 at 1 year with the LOTUS valve. This is certainly not my clinical experience with this device, and I think some other data will challenge this contention. And as expected, superiority with that important secondary endpoint looking at paravalvular leak. If I can move on quickly to look at the RESPOND study, the question that this study posed was, are those clinical trial endpoints within a very well-monitored construct of a clinical trial, can they be reproduced in day-to-day clinical practice? The RESPOND study, the 1 year data, was presented at this meeting by Nicholas van Meegen, and looking at 1,000 patients, importantly with blinded adjudication of events and an echo core lab, they demonstrated very similar information in a high-risk population. Age, 81 years of age, STS score down towards 6, which would be typical of a European high-risk TAVI population, and that 2% mortality at 30 days and 12% mortality at 1 year exactly mimics the results from the randomized trials, suggesting that this technology, when you release it into the general public, into widespread clinical practice, you can achieve excellent results. The echocardiographic data was certainly more encouraging in this, with effective orifice areas of 1.8 and low mean gradients post-implantation. Briefly, just to touch on the RESPOND extension trial, this was a 50-patient add-on study looking at the use of depth guard and looking specifically to see, does depth guard reduce that pacemaker rate to a more palatable number? Our chairman has previously described the depth guard, so I won't go over that. Again, small numbers, all-cause mortality 0%, but look at that pacemaker rate. It's half what it was in the randomized trial just by the addition of depth guard and also, of course, using experienced operators. To finish, to touch briefly on the LOTUS Edge study that was published at ACC. Small study, 21 patients looking at the use of the LOTUS Edge platform, which has previously been described. Again, high-risk patient population, mean age of 84, STS score somewhat more modest of 4.3, 100% technical success, but importantly, this device was particularly designed to get that pacemaker rate down 10.5% at 30 days. So to conclude with the red flashing bar above my head telling me to get off the stage, TAVI with LOTUS has a non-inferior safety profile to the CoreValve and is superior for that composite endpoint of death, disabling stroke, and more than moderate PVL at 1 year. These excellent clinical trial results are achievable in day-to-day clinical practice. A high rate of new pacemaker has been an issue with the LOTUS valve, but procedural refinement, depth guard technology have mitigated this limitation of first generation LOTUS technology. And the Edge promises to further improve clinical outcomes for our patients. Thank you.
Darren, I think we're going to take all the talks first, and then we'll have a discussion at the end.
Great. So next presenter is Didier Tchetche, and he's talking on how advanced control reduces paravalvular leak in my clinical practice.
So thank you, Thomas. So you've seen now. Sorry, this is not the.
You can do it again, Didier.
Yeah, you were too lengthy, so I'm going to do it short. So you've seen through the talk from Darren now. Efficient was the LOTUS to mitigate paravalvular regurgitation. So I will try to illustrate how this advanced control feature can reduce PV leak in my clinical practice. So the first question is that we should ask ourselves is, why should we prevent regurgitation? We know since the Partner 1A trial that it seems to be a negative impact of moderate or maybe even mild paravalvular regurgitation post-TAVI on the outcome, on the survival of the patients. And this has been confirmed in a meta-analysis that has been published 4 years ago that you certainly all know. And it is clear throughout registries, various registries, that there is a clear trend to an increased mortality if we leave the patient with a moderate or severe paravalvular regurgitation at the end of the procedure. But it is also clear, and this is consistent throughout the literature, that with the most contemporary TAVI devices, and you can see that on the extreme right end of the picture, we can find the LOTUS with very minimal rate of moderate or severe paravalvular regurgitation. So it's clearly a device that is suited to that purpose of avoiding any severe regurgitation post-procedure. From a mechanism-wise standpoint of view, we can see that there are 4 conceptual mechanisms at the origin of a paravalvular regurgitation. The device can be a target, but prevented from sticking to the aortic annulus and the leaflets by calcium spots. The device can be implanted too high. The device can be implanted too low, or it can be undersized. And this is true for both self-expanding or balloon-expanding devices. These are the 4 main mechanisms that we can find in our practice. So having said that, clearly the LOTUS is designed to prevent that complication, and particularly the depth guard and the LOTUS Edge, because first of the pre-shaped nature of the device to achieve more coaxiality. And second, you've seen that, Ted told you that the way the depth guard deploys is really meant to control the depth of the device and the location of the device at the end. And this is more obvious on that animation, and you're going to see standard LOTUS on the left part of the screen, depth guard on the right part of the screen, and definitely the depth guard will expand by keeping the bottom part of the stent frame exactly just below the annulus, avoiding to be too deep, and achieving a correct interaction of the surrounding structures with a high implant to decrease paravalvular regurgitation. So this is theory. Let's see now throughout a couple of examples how the various levels of control with the LOTUS depth guard and the LOTUS Edge can really and truly mitigate paravalvular regurgitation. This is a regular deployment of a LOTUS in a regular anatomy. You can clearly see that the device is controllable. You can rotate the handle very slowly, keeping the posts at the level of the annulus. And it's very simple in a regular anatomy to achieve a high position. There is no rush. There is control throughout the procedure. You can clearly determine the final location of the device, and at the end, in a regular anatomy, achieve no regurgitation at all. This is classical, and this is the target for the LOTUS. Correct implant, patency of the coronary arteries, no regurgitation at all. Let's go a step forward in terms of complexity, and bicuspid is one of the most complex anatomy that we are facing, because we know that it's first difficult to size, And most of the time, the device that has been implanted in such anatomies are smaller than the maximal diameter that they are intended to achieve. And this is an example of a patient with 23.1 perimeter-derived annulus, intercommissural distance of 25.6. We've implanted a LOTUS 23. And after deployment at the level of the annulus, the device was only 21.4. It was a 23 millimeter LOTUS. And at the level of the intercommissural level, 4 millimeters above the annulus, it was only 21. So very smaller than what we expected. Nevertheless, this was a dev quad case. With the control provided by the dev quad, keeping once again the posts at the level of the annulus to achieve a high implant. This is the patient for whom you've seen the pre and post CT scans. It's really control. You see no rush once again during the deployment. You can nicely appreciate the location, the position various times during the deployment. And at the end, what we aim at is to obtain a high implant and no regurgitation. So we can check. You can check at various steps of the procedure, even in a bicuspid patient, and this should really be the goal with the LOTUS for any type of case, any patient, high implant, patency of the coronary arteries once again, and no regurgitation, or the minimal regurgitation achievable. A step forward in terms of complexity, horizontal aorta, and definitely horizontal aorta is really challenging to handle because of the risk of malposition and the risk of inherent misplacement of the device and paravalvular regurgitation. And this is a case of LOTUS Edge in a heavily calcified and horizontal aorta, and we had to reposition the device once, but at the end you can see that it's well oriented, perfectly coaxial with the axis of the aorta, and we have no regurgitation. Another level of control provided by the LOTUS is the ability to reposition, to do minor adjustment in the final depth of the implant of the device to be sure that we have no regurgitation. This is a case from Mike Reardon, first deployment of the device with a mild regurgitation. First repositioning with decrease of the regurgitation, but still some kind of trace to mild. Final repositioning, and at the end there is no regurgitation at all. So this is something that is achievable with the LOTUS and that we should target. Last level of control, we said that there were 4 mechanisms. The last one is a device that is too small. If it is the case, it's really easy with the LOTUS to withdraw the device, to recapture it, withdraw it, and place a bigger valve. This is just an example of valve-in-valve, more complex. We can achieve a good implant and no regurgitation. So 40 seconds to conclude, and quite briefly, I have to, I'm not from Boston, I'm a physician, but clearly we have to accept that the LOTUS and particularly DevQuad and the Edge are one of the most efficient devices for PV leak prevention. And this is due to various levels of control, precise positioning at first attempt without deep implants, coaxiality maintained during the deployment, and we can activate doing more coaxiality by pushing on the catheter, so we have to target that. Full repositionability if needed to be sure that we end up with no regurgitation, and full retrievability if needed to be sure that we implant the properly sized device. Merci beaucoup.
Great examples. Thank you, Didier. Our next presenter is Matthias Gottberg from Lund, who's going to talk about all-comers experience.
So thank you very much. It's a pleasure to be here today. It's tough to be successing a very gifted colleague shown LOTUS Valve in a lot of different cases. The topic of my talk today would be a little bit about our LOTUS experience in Lund, a bit about depth garden lessons learned, some insights from Swedish Britannia's valve registry, but also international experience when it comes to pacing, and to top it off, the LOTUS Edge all-comers registry. So ever since we gained CE mark and started implanting the valve commercially in Lund, we've been prospectively data collecting. So about 65% of our patients have been treated with LOTUS Valve since 2014. And we are a Nordic population, which means that since we don't have the 29 millimeter valve, there's a significant portion of our patients that actually need to have a larger valve size. So that's have been one of the limiting factors. The other one has, of course, been peripheral access. But other than that, we're truly trying to have this in all-comers population. And we have 177 patients treated today. And of those, 97.3%, we had successful access delivery, deployment, and system retrieval. We had a couple of cases where we had severe tortuosity and we were unable to negotiate and navigate with the stiff catheter. We had one case when 27 millimeter valve was too small and we had to exchange for another commercially available valve. And we also had one case with device failure. We had to exchange for another valve. But above all, really mimicking what we've seen in the clinical trial data, that no cases of coronary obstruction, valve migration, valve embolization, TAVR and TAVR type of valve deployment. So it's really a very safe valve to use. If you're not happy with it, you reposition. Still not happy, you can retrieve it, exchange for another valve as well. So overall patient outcome is 2.8% 30-day mortality in this whole cohort. Rate of disabling stroke is 1.7%, and major vascular complications are 2.3%. In the full cohort of 177 patients, we have 14% pacing rates. And if we divide it into the different groups, among the first 50 patients, we had 18% pacing rates. And that's when we're using the classic approach of expanding the valve in the LVOT and then pulling it back into its final position. And then we changed the implantation technique and achieved a lower pacing rate. Among the last 77 patients, we have a slightly higher pacing rate, and this is due to the fact we had 2 new operators, but also we had a learning curve with the depth guard. Once we got it, we were actually the first ones to start using depth guard, and we didn't know how to implant it at the time. So I'm not going to dwell too much on the depth guard technology in itself. I will note, though, however, that with the current generation, it's more difficult to implant with depth guard than it was with Edge. So Edge and depth guard really marry each other very well because the flexible catheter means that you have less push on the septum and the valve centralizes earlier during deployment. So it's really an easier way to use Edge together with depth guard. It's really something that in our continued experience that it allows for more predictable placements. So in one of our early depth guard cases, I think this is one of first or second, we started off with a pretty low deployment, showing you not how to do it. And what happens is as the valve is being expanded, it's being pushed into the LVOT. And this is very common with the early experience. And of course, if you expand the valve in the LVOT, you take a pacemaker hit. And this is really what we did. In the first 5 cases, I think we had 4 patients that needed new pacing. See, now it's starting to expand, and then it's going to push down. So this is way too low. So like Didier alluded to, see if I can, like Didier alluded to, if we start off higher, it's also easier to maintain that height. So we start off with a high initial deployment, and we employ a gradual traction on the catheter. It's really easy to keep the valve at the correct heights. And together with depth guard, it means that we have all the shortening from top down. So it's very easy to get that final position without having too much interaction with the LVOT. And this is something that should reduce pacemaker registry, and was also been observed in the RESPOND extension registry. So gradual traction on the catheter to maintain valve implantation heights. Other lessons learned is that the amount of radial force exerted by the LOTUS valve depends on where you put it. So you can use this to your advantage. If you start off with a high deployment, it means that you actually have less radial force being forced onto the LVOT. But it's also a way in a heavily calcified valve, you can do a couple of resheaths and use this as a mechanical BAV. So it works both ways. But the topic of this is just having a high final position means that you have less radial force on the VLT. So it makes sense to start off high and end up high. The lessons from the Swedish percutaneous valve registry, and we have 3 centers in Sweden who use the LOTUS valve, and overall we have very good data, sub 20% data, despite that 2 of the centers are new to the LOTUS valve. And the other international experience, RESPOND extension, less than 18%. The Monash experience, 18% as well. Kigali, 14%. Nordic Registry, 12.8%. Chris Maduri, after changing his implantation technique, 12.5%. Our experience overall is 14% as well. So I would say we can achieve favorable PPN rates if we use a high implantation technique. And the depth guard design is something that really facilitates this. So in terms of our experience, we have an excellent performance with low mortality, low stroke rate, and now Ted's shown it as well in the REPRISE 3 trial, a very favorable clinical outcome. We do have very good pacemaker rates despite having new operators, despite having learning curves. It's nothing that really mirrors what we've seen in the REPRISE 3 trial. Changing implantation technique definitely reduces pacing rates. And also, finally, we have a Lotus Edge all-comers registry. So as soon as we will have the Lotus Edge valve back on the market, we will have the ability to track all the Lotus Edge implants in an international registry. And interested investigators are all welcome to join this register as well. So we will try to recruit 1,000 patients in less than a year and do a 1-year follow-up looking at both safety and efficacy outcomes, which will be performed according to VARC true criteria. So thank you.
Thanks, Matthias. Our next presenter is Jan Malte Sinning from Bonn. My experience with Lotus and other devices.
Thank you very much for the kind introduction. Ladies and gentlemen, dear Chairman, it's my pleasure to share with you my experiences with the LOTUS Valve and other TAVI devices from our clinical practice. These are my conflicts. And first of all, let's ask what are the remaining challenges for the current TAVI devices we are using in our practice. And there is a big 5 consisting of paravalvular leakage, vascular complications, stroke, acute kidney injury, and conduction disturbances. And as we all know, except for these conduction disturbances, the first 4 complications are all associated with mortality, what we know from several nice sub-analyses. But with the introduction of next generation devices and with reduced sheath diameters, repositionability, and paravalvular sealing mechanisms, we were able to address, at least in part, these drawbacks of the procedure, PVL, vascular complications, and also conduction disturbances. But we have to keep in our mind that there seems to be a kind of interaction between the degree of oversizing and maybe explaining this relationship of a very low degree of PVL, and on the other hand, depending where the valve is deployed, the occurrence of new conduction disturbances requiring a permanent pacemaker implantation. So in the sub-analysis from our registry in Bonn, which I'm going to show in a second, we decided to compare something old versus something new. I mean, it's not only the car, but also the driver, which makes the difference. And here you can see the valve types we have used in our center so far. And we decided to compare first-generation devices versus next-generation devices. And as we all know, I mean, this is not a randomized comparison. I'm going to show you there will be a strong selection therapy bias. But these are consecutive patients from our clinical daily routine. And this is kind of an algorithm we are using in our practice to select these patients after the introduction of next generation devices. If a patient has transfemoral access vessels below 5.5 millimeters, we predominantly use the Evolut R. Maybe if the patient had tortuous vessels, also with a stiff Lunderquist wire, or if it was only a localized stenosis, the patient underwent PTA of the iliofemoral axis first before the TAVI procedure, or definitely there's also an option. We chose an alternate axis. In these times, I would say it's below 10% non-transfemoral TAVI case in our center. And if vessels were fine, we had the choice. Aortic annulus sizing was done by the CT criteria we all know and according to the manufacturer's recommendations. But as we have learned from the previous talks, there are some anatomic challenges which might be better addressed by a specific device. And we thought that, for example, in calcified aortic annuli, the LOTUS or the Evolut R would be the preferred choice. Horizontal aorta, I think Didier has nicely presented that already. Lotus or SAPIEN 3. Low coronary takeoff, I mean, in these cases, you should definitely use a repositionable device such as the Evolut R or Lotus. Bicuspid valves, I think the Lotus valve has been the most perfect valve for these cases. SAPIEN 3 is the only one available in these times. And large anatomies, I mean, we waited for the Lotus 29, still have to wait a little bit more as it seems, but this is also a topic which can be quite challenging, as we also saw in Matthias' talk, because some of these patients have larger annuli than 27 millimeters. So in this sub-analysis, 805 consecutive patients from our center have been included from 2008 to 16. Most of our procedures, as it is quite typical for a German center, are performed angiography guided with a hemodynamic assessment under conscious sedation without GA. And in this sub-analysis, we focus on the hemodynamic evaluation of first-generation devices versus these next-generation devices. You can see at the bottom of my slide, and altogether it's approximately 40% next-generation devices in this sub-analysis. And to save some time, I want to directly focus on the main results of the sub-analysis. As you can see here on the right-hand side of the slide, more than mild PVL, more or less diminished with use of these next-generation devices, and especially the SAPIEN 3 and Lotus valves virtually eliminated this issue. And as you can appreciate in clinical daily routine, less than 20% of the Lotus patient only showed mild PVL at the end of the procedure. Another thing which is quite important is the hemodynamic situation after the implantation, and I just want to focus on the aortic regurgitation index, which we introduced several years ago, and we also found for this topic significantly higher values for the next generation devices, with the highest values achieved for the Boston Lotus device, as you can see here on the right. And even in these next generation devices, there seems to be a stepwise decrease with an increasing degree of the PVL severity. And why is this important? I mean, we have shown this several years before, and it's also can be nicely shown in the ongoing cohort. With a decreasing AR index after the procedure, prognosis gets worse. And as you can nicely appreciate here in this Kaplan-Meier curve, patients in the in the lowest quartile with an AR index below 24 had the worst outcome, which was also stable over time, even with the use of next generation devices. And I would like to show you a summary of our clinical outcomes, and this is a more recent slide, including some more patients than these 800 patients from the hemodynamic sub-analysis to render it a little bit more interesting. With next generation devices, 30-day mortality could be reduced significantly. I mean, as I already told you, this is also some kind of learning curve effect and maybe better patient selection, the trend toward intermediate risk patients. But you have to keep in mind, as already Dr. Feldman pointed out at the beginning of this session, that this 2 to 3% 30-day mortality also includes high-risk patients, extreme risk patients, and some emergent or urgent patients which have been treated. Pacemaker rates could be reduced with repositionable devices. With the Lotus device, we had a slightly higher rate of pacemaker. Stroke was a rare complication, luckily and fortunately also with the repositioning device features, it did not increase. Coronary obstruction hasn't been an issue at all in these times with the next generation devices, and major bleeding as well as PVL could be reduced significantly. And with a red flashing bar above my head as well, I'm just briefly showing one example of a challenging anatomy to you. This has been a female patient undergoing TAVI with a bicuspid, bicommissural rapid type aortic stenosis. And to save some time, we also did assessment, as we have seen by Didier. And in this case, it was quite elusive to do a balloon sizing with a ZMAT 23 millimeter balloon. And we finally ended up with a classic Lotus 25 millimeters valve, which we implanted a little bit higher in this specific bicommissural anatomy, and finally ended up with a very nice result, I would say, which was stable over time, no pacemaker, no stroke, and a mean gradient, even 6-month follow-up of 13 millimeters mercury. What is next? The SELECT trial is something we are eagerly waiting for. This will be a randomized one-to-one comparison of the LOTUS Edge device versus the Evolut R, or maybe also versus the recent Evolut Pro generation in all-comers TAVI cohort, including 360 patients. And primary outcome will be the early safety at 30 days, comparing these two valves in clinical daily routine. And finally, I would like to briefly conclude, as you have seen, learning curve, better patient selection, and the trend towards intermediate risk patients have a beneficial effect on outcome in TAVI patients. That's quite clear, I would say. But also the use of next generation transcatheter heart valves addressed several procedure-related shortcomings and leads to improved outcomes. And in my opinion, the remaining challenge still is to find the right valve type and size for the specific patient. And I would say, and I think the previous talks already nicely pointed out, when facing certain anatomic challenges, it might be preferable to use one valve type over another. Thank you very much for your attention.
Thanks, Jan. So I think we're going to have the discussion, but we want to involve you guys as well. So, but I can start asking you, Thomas, as a surgeon. What do you think is the most important thing to address when you replace an aortic valve? Do you have major concern about pacemaker or PVL?
Well, the presenters very nicely pointed that our PVL, there's obvious data that we should avoid mild and moderate and severe PVL, because that directly affects the outcome in terms of increased mortality at 1 year and in longer term studies. So it's very clear that that's number one. You shouldn't have PVL. And actually, we as surgeons were always told by cardiologists, when you put an aortic valve conventionally, there's a leak. That's a problem. You didn't do a good job. Having said that, pacer, there's studies indicating now that pacers won't have negative long-term effects, but 1 year effects. But I'm not sure whether we know that in the long run. You know, we sometimes see pacers who cause some tricuspid incompetence and I believe we need to wait a bit longer and see whether need for placing a new pacemaker will affect the longer term outcomes of those patients. So it's an important point, especially when we go to younger patients. When you're 80 and you get a permanent pacemaker, maybe that's all right. When you're 60, get a TAVI valve. Some people dream that we will treat 60-year-old patients routinely with TAVI in the future. Then we need either the high placement with the low pacer rate, or best would be to have no need for a pacemaker.
So one paradox that we're starting to appreciate is that in the younger patients, bicuspid anatomy is more common. And LOTUS, well, all devices now we appreciate deploy higher in a bicuspid valve. You're anchored in the leaflets much more than the annulus. And LOTUS in particular seems to be getting good results in terms of adapting to the calcium and not causing annular or root rupture as the calcium is displaced outward. So I think it'd be a kind of a paradox that in this large, it's a subset, it's almost the bigger part of the set for the young patients, that lower pacemaker rates, because we're landing in the leaflets, may be actually facilitating treating this part of the population of young patients.
That's a true point. I believe bicuspid valves, of course, are more frequent in younger patients. And one other feature of the LOTUS, the full repositionability, is probably a very important point if you go to younger patients with a specifically difficult anatomy, which could be a bicuspid or heavy calcifications, because you can just take it completely off if you're not happy with the outcome. Therefore, I think that's a good feature.
But I think everyone, we agree that LOTUS is doing very well in bicuspid valve. But do you think in the future we need valves with a specific design for bicuspid valve, aortic stenosis, aortic valves? Because we're using valves which is actually designed to work in a tricuspid environment.
It depends. Actually, recently I spoke with someone, and we all know this rapid printing, this printing of any devices. Maybe in some years valves could be printed. I'm not sure whether it's the combination of a frame plus some leaflet tissue can be printed, but maybe then you could develop some individually fitting valves that you have the anatomy of the patient, then you print the right valve for this patient. Maybe, I don't know.
Lars, what features are you suggesting that would be specific to the bicuspid as a target for a device?
I mean, if you just look at the data we have, even with the newer generation valves, they're performing much better than the first generation, maybe also because we have a better understanding how to size these valves and how to implant them. But you still have less favorable outcome than in tricuspid valve. So you could assume that maybe if you have a valve which was designed for sitting in a bicuspid valve, you may have better outcome on pacemaker, on PVL, paravalvular leak, and so on. I'd have no good idea how it's actually going to look like, but I can just see for the time being, quite a few of the valves on the market do not perform as well in bicuspid valve as in tricuspid valves.
So the Chinese have a valve that looks very similar to core valve, the venous valve, and a very high proportion of Chinese with AS have bicuspid, clearly higher than in the West and even in Japan. And the venous valve has been apparently engineered to have a special large amount of radial force in the bottom third or so of the stent frame. And I think the hypothesis, yet to be proven, is that this is going to be better suitable for the bicuspid population. So I think it's possible that special design features might work for bicuspids. But I think the feature of LOTUS that we have discovered as an advantage in the bicuspid population is that the controlled mechanical expansion won't overcome the calcium. So when you use a balloon expandable, you deploy the valve, it goes to its full expansion, the calcium is forced outward abruptly, and that's where it's sub 1%, but there are annular ruptures that are catastrophic. And with LOTUS, I think what we all see is that as you turn the handle, you can't expand that rapidly. And this slow displacement of the calcium, this may be the design feature that is for bicuspid, not by intention when the design was created. And we welcome comments from anyone in the audience and our other speakers. If you have any additional comments, that would be great.
Matthias, you're sitting with the mic, so I can just ask you about the pacemaker. If you look at all studies, the pacemaker rate from side to side have an enormous variability. Some have a very low, some have a very high. Do you think one of the most important factors for the pacemaker rate is the actual indication at the specific institution when to put a pacemaker in?
I think it's a very good question. Yes, of course it does. We know, for instance, if you have a financial incentive to implant pacers, you have a higher pacing rate. If you have the indication to implant pacers immediately post-operative versus the first day, you have higher pacing rates. So it's really what it comes down to your different practice. And I'm not saying that anyone should change their practice. We know that we're in a level play field with any other valve manufacturer in terms of this. But what we see is that of course affects the pacing rates overall. And this is why when you look at pacing rates, you need to take that into account and look at the larger registries as well and larger data sets. So for instance, Nordic Registry, where we assembled data from several sites around the Nordic countries where we achieved lower pacing rates. So I think that with the same implantation technique, you could probably have 10% pacing rates and 20% pacing rates, but you're not going to have 35, 40% pacing rates.
So what is your current practice for implanting a pacemaker? You have a very low pacemaker rate with a LOTUS.
Yes, I mean, it's usually not in my hand to decide when we implant a pacemaker or not. So we typically decide that day one at the ward, and it's the physician that's head of the ward that decides this. So pacemaker indication is totally out of my hands, and we don't leave the temporary pacer in for 2-3 days. We do it the next day, because in my mind, I think it's more dangerous to have a patient immobilized for 2-3-4 days before you get the pacer in, rather than put the pacer in those patients who are doubtful whether they need it or not. So we possibly even put in more paces than we need to. But the next day, I don't think you should do it immediately afterwards.
I fully agree with that, and actually that's probably practice in most sites. You don't want to risk the patient when there's an AV block or anything, but we do not have good data. We looked at a few patients from our center once. How many of those patients who receive a pacemaker for some of these kind of variable reasons require the pacemaker after 30 days, after a year? And there are probably several who wouldn't need a pacer in the long run.
So you're hitting on a really critical point, and in the Reprise 3 trial, we have a part of an algorithm. All of the new pacemaker implanted patients are going to have a systematic evaluation for pacemaker dependency at several time points in the first year. And nobody's done this prospectively. So, and it's you turn the pacer down 10 beats every couple of minutes until you see whether they're dependent. So we will have very good data that define how long is the pacer dependency. The next challenge is just pick a number, and I'm going to guess that at least half the patients will not be pacemaker dependent at 6 months. Well, you can't not pace them on day 2. There are, I understand, several startup companies that have intermediate design pacing devices. And in the low-risk population, this would be a fantastic answer to be able to say we have a device with a lead that can be easily removed after, I don't know, so many months to exactly address this issue. I'll say there's another backhanded finding, and we are just starting to look at this. Again, the Reprise 3 data set is a big population, very rich data set, and I've only had a preliminary look. I'm not sure if this is going to turn out to be measurable or significant, but it really does look like there's at least a little bit of better survival in the new pacemaker group compared to the not new pacemaker group, and we all appreciate in a high-risk group, especially, they're older patients, and TAVR aside, we may be forestalling a couple of sudden deaths with the pacemaker implants. This is not an advertisement for pacemakers.
Any other questions?
Well, we have a couple of minutes. We did make a number of other observations in the Reprise 3 data, and I'd love to get a couple of comments on one small number but high impact finding is we had, as you would expect with the LOTUS valve, no malpositions, no acute TAV in TAV. Or valve in valve. And I think everybody who's used core valve has had the experience of a pop out. Infrequent, but significant when it happens. So any reactions to how important this finding is?
I guess, again, we don't know. We don't have data on outcomes of patients who require a second valve during the procedure and how the long-term outcomes will be. Will there be higher thrombosis or earlier degeneration or same outcome like in the overall population? We don't know.
Well,
Cost is another issue, but I'll leave cost aside. First, the patient.
Matthias?
Well, of course, I think that valve embolization is something that is a predictor of mortality, and it's always difficult when we're doing a randomized clinical trial to know whether that specifically affects mortality in that trial. But it's an infrequent event that is very serious for the patient in question. And if we would have a tenfold size of the trial, of course it would affect outcome. And this is one of the great safety features of the valve, which we appreciate the fact that You can put it in. If you're not happy with it, you can reposition it. And just the fact that we don't have any occurrences of pop-outs. And this is the main feature of this valve in my mind. I just want to touch base on quickly on going back to the topic of pacing, is that the best feature of the LOTUS valve is the repositionability feature, but it also adds the variability in implantation technique. And this is really the main caveat so far. It's not the technology in itself, it's the fact that we didn't know how to implant this. This is a learning curve, the great learning curve along the way. So we had different implantation techniques, but now we are converging on an implantation technique which we are going to employ when we're proctoring in the future, which hopefully will reduce pacing rates significantly. But it's the individual site experience that we're trying to encompass into a uniform implantation technique.
We do have a comment from the microphone, Dr. Hahn.
Just a question. I guess in Reprise, it seemed as though the valve areas were smaller with the LOTUS, but not seen in some of the other single-site studies. Do you think that that's a real phenomenon? And one of the advantages to TAVI over SAVR is obviously patient prosthesis mismatch, and is that going to be lost with LOTUS, or do you think that that's not a real phenomenon?
No, that's a really important question. Respond, which was multi-center and had a core lab, had valve areas closer to 1.8, first of all, so it's not something we've seen in every experience. In this study, if you just take the numbers at face value, the LOTUS numbers are similar to or a little greater than typical surgical valves, so we still have some advantage. The gradients were absolutely flat for both LOTUS and core valve, and the fact that the valve areas varied and the gradients didn't, we haven't figured out yet. So we do have some core lab systematic measurement that we have to look at.
So
Okay.
Lars is giving the final words.
Yeah, and I'm just going to show you 2 slides. This was actually the first one. So looking into the future, there's a valve on its way after the Edge, the LOTUS Mantra valve, which have several features. First of all, it's a shorter frame. It's going to be 16 instead of 19 millimeter height. It's going into a reduced profile. You can use a 12 French compatible sheet to introduce it. And it have the same features in otherwise like the current LOTUS valve. And the final just about this slide. So if you want to have more information about pacemaker and how to optimize your implant using the LOTUS valve, go to the session tomorrow morning. Dan Blackman is going to give you some data from the Respond extended study. So I think I want to thank all of you to attend it, for my co-chairman, Ted Feldman, Thomas Walden, for the speakers for a good session. Thank you.